introduce to Dr. Michael Scarcello, who is a registered nurse with 25 years of professional experience in Northern Ontario. Michael earned his honors Bachelor's of Science in Nursing from Lakehead University in 2000 and has completed a Master's of Arts, which specialized in clinical nursing, as well as a Doctor of Nursing Practice at the College of St. Scholastica in Minnesota. And that was in 2009 and 2018. Michael has definitely kept himself very, very busy. And congratulations, Michael, on recently finishing your doctorate. That's amazing. Michael's professional practice has spanned a range of acute care and educational settings with a sustained commitment to advancing nursing scholarship and practice in the northern and rural contexts. His research interests centers around his area of work and within that nursing education. So, Michael, we welcome you. We thank you for being here. We really look forward to your presentation. I've worked with you in the past, and I'm always just in awe of what you are doing there at Confederation College with your amazing team, because I know that you work with many others that are just doing incredible work. So I would love to hand it over to you now. Thank you.
Thank you so much, and welcome to everybody. Just going to do a quick voice check. Can everybody hear me? Maybe put a hand up for, yeah, awesome. Thank you so much. I'm so pleased to be here. I have been involved doing work with RNAO since I was a nursing student in 1996. So that ages me a little bit if anyone's doing their quick mathematical calculations. Um, so I've been involved for that amount of time, and when it was being presented that the webinar would be recorded and archived, I kind of thought to myself, wouldn't it be neat if, like, in 100 years somebody found this and they were able to like see us all, and like, oh, they were talking about this, in 2026, and whatever year it is when we're found. Um, Maybe all the problems that we have in the world may be gone and, be on to bigger and better things. So fingers crossed. So thank you so much for the really warm welcome. It is my extreme pleasure to be here today to speak about the work that we're doing at Confederation College in the practical nursing program. Definitely, we are extremely proud of this work, and to be called upon by RNAO to present on the work that we're doing, to initially be invited to be a BPSO was definitely uh, an honor for us. And I'm here today to speak on the work that we're doing. This presentation is co-authored by my colleagues, Dr. James Robbins and Lindsay Yon. And so I'm pleased to present to you today about our work. I hope you'll pepper me with all sorts of questions at the end, and I hope that we can stay connected following the presentation, because I believe that the work that we're doing should be shared, and we should also learn from what other sites are doing. Thank you so much. So we were initially called upon in 2024 by Dr. Doris Grinspun to participate in BPSO as the first Indigenous led curriculum in practical nursing in the province. Now, there was another college that was doing partial work with the Indigenous focused component in part of the program, but we were a first in that we were attempting to infuse Indigenous learning outcomes throughout our entire curriculum, not just one part of the curriculum, but all of the curriculum. So in 2024, we were called upon to consider involving ourselves in this work. And as I said, it was something really important to me, not only as someone who had been with RNAO for 26 years, for somebody who has taught in the practical nursing program the majority of my career, and knowing that RNAO's mandate is really about registered nurses, nurse practitioners, and nursing students. It was very I was very proud of the moment because we were able to open up a door and show the work that we're doing and look for synergies in that work. So in 2024, we were called upon to take part in this work. So in terms of the planning piece, it is a 3-year process that we followed, and that you all know about that, and some of you folks have been involved in BPSO. Definitely, there's lots of planning, and at first when we first started this procedure, this project, it was very sort of like scary because I was like, oh my God, like now, oh my, I have to get a cake. I need to get orange and green balloons. Like, what's going on here? And it was nice because as it kind of went on, we had myself and my team, we worked well together, but we also had this enormous support from RNAO. And so that planning piece, that was something that we were a little bit scared of in the beginning, became very simple. So we were supported by everyone at RNAO, specifically Dr. Doris Grinspun, Grace Suva, Kate Hansen, Tanya Costa, definitely. And of course, my colleagues that are on the line today, always cheering and supporting us in the background. So the launch occurred. We developed a steering committee. It was really important that we had administrative and faculty involvement. We promoted champions training with our staff, nursing for sure, and non-nursing, and many of them involved themselves in it. Student involvement was important and needed to happen immediately, and we actually infused the champions training into the students' first professional practice course. So in semester 1 of their program, they take professional practice 1, and one of the assignments which we give credit for is a completion of the champions training. So it is a prerequisite for them to continue on. I mean, we're not going to delay somebody from moving into the next semester, but we will make it very clear that in order to start clinical placement, that they need to have the champions training. And then community support. So lots of local partners and local champions that we invited to our initial launch, where we would wanting to share, this is what we're planning to do. This is where we'd like to go. How can we work together? We were just basically advertising ourselves as up and coming. We're moving into our 3rd year right now, so it seems like only yesterday that I was going to Metro to get an orange and green cake, and here we are on year 3, so it's good. I'll take you back a little bit to 2012, an important year for us at the college. And at that time, we had a committee that was called Naganoan Education Circle. And Naganoan Education Circle, which is now called Naganoan Education Council, was initially made up of 7 elders, traditional knowledge keepers, and community members. And those community members, whom we now refer to as community scholars. Um, it was in 2012, and much work had been done prior to that by the committee that was initially made up of elders, I might add. They wanted all of our graduates at the college, whether it was graduates of nursing, graduates of welding, or graduates of, secretary, that they all graduated with at least one of the 7 Indigenous learning outcomes that were being gifted to students by the committee. So that was in 2012. So we would get the 7 out, we all received the 7 outcomes, and we were responsible for infusing one outcome once within our program. So that was 2012. There is many programs where that learning outcomes infused very easily. For example, nursing, anything community service related. There was difficulty in infusing concepts in some of the science courses, but as we moved along, we all got more and more comfortable, were able to do this. So that was in 2012, and in 2012, we really saw the writing on the wall in that all 7 of these outcomes are all applicable to nursing. How do we start doing this work? And at that time, we also had a discrete course within the program. So you had the option of infusing that one outcome once within your program, or you taught, or the students received the discrete nursing or discrete Indigenous focused course within their program. And most people opted for the Indigenous focused course because it was taught often by an Indigenous person. So it was in Indigenous Canadian relations, or Indigenous identity, land, and that kind of stuff. Discrete course. And it was a great idea in the beginning because it pulled the nursing faculty away from that work, but also and it allowed the expert to teach. But the problem was is that we weren't learning alongside our students. And it was the elders who wanted us to actually walk and learn alongside. So it was a really neat teaching opportunity for everybody. So when I started teaching the outcomes in 2012, it was scary for me, but I just had to you had to be like, okay, I'm vulnerable right now. I'm learning alongside my students and this is how it is. So that takes us to 2015. Now we're becoming a lot more comfortable in doing this work. And at that time, the TRC calls to action came out, and we know about the 94 calls to action. And frankly, we know where we are at in Canada with the 94 calls to action. I feel like in my program and in my space, like we're doing good work, but I also realize that our students leave our space and sometimes they're impacted by other spaces. So I like to give my students the best possible um, tools as they leave my classroom. And then in 2019, the RPN entry to practice competencies from CNO changed in 2019-2023. Entry to practice outcome number 22 and 70 speak specifically to the integration and application of calls to action, and CNO ETP 70 speaks to the integration of elders and traditional knowledge keepers at the bedside as partners within the care. So we have these three guiding documents that really took us into BPSO and the implementation of our first guideline, which is the foundational guideline for BPSO in academia, I believe in clinical spaces as well, the Transitions in Care and Services document. So here is what one of our ILOs look like, or the Indigenous Learning Outcomes. So you'll see the outcome number one, and this is what's presented to faculty, and it just makes it so simple. When you, as a non-Indigenous person or a settler to Canada, when you are having to teach the content and do it in a respectful way. So the first outcome that we were gifted, relate principles of Indigenous knowledge to the career field. And so you'll see that there's the knowledge, skills, and attitudes that you can apply to meet that outcome. So, for example, in my course, in my pharmacology course, I teach a strand on traditional medicine. I am not the expert. I have become someone who knows a little bit. That's all I am. And I teach the students what I know. And what's really great is that often our Indigenous students in the classroom teach us what they know. And we're constantly looking for books and articles and things like that that might take us to new learning. But since the past couple of years, as a culture which is very much oral tradition based, you often are not going to find a peer-reviewed article on something, but you will find land-based teaching opportunities, oh plenty, in Northern Ontario. And through our BPSO work, we have met Natalie Hache from Anishinaabe Mushkiki, who's a traditional medicine woman. And these are the opportunities that we look for to meet those learning outcomes. Bring the people into the classroom, create space for that person, and forget about books and articles and learn from the expert right then and there. And it's been great. So we have our outcomes. There's seven, and the knowledge, skills, and attitudes, which you can follow along in order to learn this work. If you're interested and you want to see all seven outcomes, maybe I can share my email, or I can share some sort of way to contact me, or you can Google Confederation College Indigenous Learning Outcomes. It'll give you all the information that you need. The only thing the elders ask is that you give credit to Nagano Education Council. Okay, so our steering committee is co-chaired by myself, Dr. Robbins, and Natalie Hache, whose name I have mentioned. We've been involved in speaking engagements such as this, including panel and poster presentations. We're actually going to the Canadian Association of Schools of Nursing next week to present on this work. And again, a time when practical nursing programs are being invited into traditional RN spaces or traditionally like RN school spaces to present what we're doing so that way that work can be taken on into other areas. So it's really special for me. Practical nursing is in my core, in my heart. I am a registered nurse, but my heart lies with basic, good, solid bedside care. We've been involved in social media. We've had open houses and marketing, as I mentioned, champions training, and this is all work that is highly supported by RNAO. We do a newsletter twice a year. And in the upper left, there's a picture of Natalie Hache. She is our traditional medicine woman from the Anishinaabe Mushkiki. On the top, you'll see two of our students in the simulation lab. And this is the day that Dr. Doris Grinspan came to Thunder Bay and spent the day working with students in the simulation lab. And we brought to life the Transitions in Care and Services Guideline in a simulation. And that's what you see on the top there. And on the bottom right is Jean Boschkaken. He is a local Indigenous artist, and he gifted to us the very first BPSO pin that is special to the practical nursing program. He designed it. He designed the color schemata. He is a fellow from, I believe he's from Pic Mobert. And but he does live in Thunder Bay. No, I'm sorry. He's from the Fort Francis area. My apologies. And he designed the medicine wheel and its positioning for color, as well as the logos that you'll see as part of work that he did, getting to know us at the college and presenting students with this pin. So we were really excited to give that pin to our very first cohort this year. We had a luncheon again attended by Dr. Doris Grinspan here in Thunder Bay, and that was the day that the session also included the simulations. Okay, so in the first year of our program, so the professional practice course, the therapeutic nurse-client relationship course, we start to involve and infuse the transitions in care and services guideline. This guideline is laddered throughout, so you'll see it presented in a very basic way in the first year courses, a semester one course, and then we start to ladder it. So they learn about the guideline, but we ladder it consistently and constantly, and we're always talking about transition. And one of the big assignments that we do around this is a transition of care of a person from an acute care hospital in Thunder Bay, so our 450 bed hospital here in Thunder Bay, all the way to 1 hour flight to a community where there is no hospital. And what does that transition look like? We start to think about those kinds of things. And the guideline is presented theoretically, it's presented in simulation, it's presented in labs, it's presented in clinical, and it's not it's formally presented in the beginning and it continues to be formally presented, but it's presented using different pedagogy. So we want the students to bring it up themselves. We don't want to always be bringing it up, and that's where the laddering occurs. We have infused the diabetic foot ulcer. We start that in our first year. So in the nursing assessment course, labs and clinical practice, and advanced theory courses. This was the guideline that we chose. So the foundational guideline of the transitions in care and services, we chose the diabetic foot ulcers, and then our last one is the people-centered care. And we're also in the background infusing engaging clients who use substances and delirium, dementia, depression. So this guideline is very applicable to the North. Indigenous people in northern communities north of Thunder Bay, and when I say north of Thunder Bay, I mean beyond Pickle Lake because that's the most northern road that you can get to beyond Thunder Bay. The statistic I read recently, 7 times more likely to have a like unnecessary amputation. I'm not sure if that's the word, but an amputation that could have been prevented. And we're hoping to infuse this guideline within our curriculum and spread it throughout the North. Because the guideline has extremely applicable information that we see, our students see every day in the clinical setting. As I mentioned, we're also infusing the people-centered care and into our first and second year, and it's laddered throughout. We've had our students do diabetic foot working groups in the hallway, presenting some of the work that they're doing, some of the information that they have learned, and sharing information. And everyone likes to walk by the cafeteria on their way to get lunch, and they walk by a necrotic toe, and it's our opportunity to talk about RNAO and the guideline and the work that we're doing. Our students were recently involved with foot care workshops. So, semester one, foot care nurses came into the classroom and brought to life the diabetic foot ulcer and helped students to understand some of the assessments that they were learning in the nursing assessment course, which, of course, are evidence based and from the guideline. When we're talking about the diabetic foot ulcer, this is, I guess, our second newest guideline. We are really starting in semester one, day one, with things like basic hygiene and protection of the integument. And we want students to understand. I am a stickler for this, and I can't let it go, that basic care is the hallmark of everything that we do. It is the hallmark. And it starts with something as simple as protecting the integument. And that's just how we ladder things when we're talking about the diabetic foot ulcer. And you'll see an example of a learning outcome there, which I'm happy to share with you if you ever wanted one, or wanted an example of one, some of the things that we do. But these things start with basic protection, basic hygiene, basic, and then we move the student up, because there's no, in my mind, there is no sense talking about offloading devices and protecting patients from stage one pressure injuries when we haven't even solidified the concept of basic hygiene and protection of the integument. So that's how basic we go, and that's how basic I think we should go. We again talk about the offloading devices, uses of the Braden scale. Again, these are all part of the outcomes, all part of the guideline, and just some examples here of some of the learning outcomes that we have used, and things that and evidence that you'll see in the guideline. Again, very applicable to the work that we do with our patients in the clinical settings where we go. The students start out long-term care. They go to complex chronic care after that, following that acute care, and then back to complex chronic care, and then their preceptorship. And the students, I would say 20 years ago, the students all wanted to go to acute care, labor or maternity, pediatrics, emergency. They wanted acute care. Now our students are asking for community placements. They're asking for Indigenous focused placements. They're asking for nursing stations in the north. They are asking for wellness placements. They want to do different things. So, I also have my opinions on this. I kind of think that, for me, I needed to spend time in acute care in order for me to go on to these other areas, but I don't know if I'm right about that anymore. At the same time, I'm still in acute care. So that was 26 years ago. I planned to stay for a couple of years, and it's been 26. So, between my teaching job and the hospital. Again, examples of the learning outcomes. We we apply the ideas of the social determinants of health because we're looking to give students backgrounders on why these things are important. So when we're talking about the protection of the skin, when we're talking about diabetic foot ulcer, when we're talking about prevention of unnecessary amputations, we first need to talk about food, shelter, hygiene, cleanliness, running water, fresh water, clean water. And these are all very basic concepts that we talk about in the social determinants, but they're ginormous in that they affect every aspect of someone's life. So before we can talk about prevention and maintenance of or protection of skin and prevention of the diabetic foot complications, we need to go right back to the beginning and talk about access to food, access to running water. These are all important pieces, and this is what I mean by basic. Basic, but super important. We implement the truth and reconciliation calls to action 18, 19, and 20. We talk about how those inform the nursing assessment. Again, all part of the guideline. We look at the patient discharge summary in the My Transitional Care Plan, and how these how the diabetic foot ulcer plus the Transitions in Care and Services Guideline work together to help us discharge our patients into the community beyond Thunder Bay. So discharging to the community will formally be implemented in fall of 26 of this year. As it stands right now, our discussion, our transition that we're speaking to is hospital to health center, not necessarily hospital to home in a northern community. We are we have implemented a patient education assignment that students apply in their semester one lab, and it's actually quite neat because, when we are evaluating students, one of the things that we do is that, you have to use APA, you got to use a book, you have to use an article, you've got to do this, you've got to do that, and we have students look beyond that in terms of formalizing their work. So this patient education assignment that we have the students do in their first year lab, we have them apply visual ways of demonstrating what to expect, use land-based ways of describing the experience, use language, include other aspects of culture within the teaching tool, respectfully approach elders or traditional knowledge keepers about traditional health and wellness. We do have an elder in residence at the college, and our steering committee members are always willing and available to speak to students. The work is a lot, and we lean on them a lot. Um, but together we're all working hard to to help the student be as well rounded as possible. I often tell the students, not we can't always access an elder or a traditional knowledge keeper, but one of the things that I do, and the way I have learned at a lot of things, or learned about things to question, ask, and seek clarification, was by watching APTN. I watch APTN and I learn all sorts of things about Indigenous people within Canada, within my own province, and ways in which I might understand things a little bit differently. We have had some great examples of patient education assignments. We've had students create traditional recipe books in conjunction with an elder. We've had safety briefings done. We've had what to do if you're on peritoneal dialysis and you don't have running water, like that. So some interesting um, patient education assignments. The one thing that we're working on right now, if anyone in the room has ideas for me, we use a rubric. This is what it looks like. And we have learned that using rubrics to evaluate isn't necessarily an Indigenous focused way of doing things, and sometimes there's other ways to evaluate learning. So we are actively seeking ideas on how we might take our rubrics and revamp them in a way that is a little bit more meaningful for learning. Um, Rubrics are very Western. And academia is very Western in that it has a start and end date. And sometimes learning goes beyond those dates, but we need a way to navigate that. So we are working on that as well. In terms of monitoring and evaluation, we're always surveying our students at specific times in the program. We're surveying our steering committee members. We're involving them in work. The steering committee right now, they are involved in a lot of the cultural advisory. And that is a lot for them. And I think if I was to do this again, I would definitely have the steering committee, but I would also have an offshoot of that steering committee. And that steering committee would be a cultural advisory committee for this particular type of work that we're doing. Lots of in-class presentations and activities. We're always connected to the CLOs, or the course learning outcomes, and the Indigenous learning outcomes, and we're connected to class assignments. So we're always monitoring. I would say monitoring in brackets changing and evaluating. Our work is always evolving, and that's the beauty of this. So when you have the opportunity to do this, you'll find that it's forever changing. We see that students are applying good practice statements within the clinical setting. We notice our students are working differently. They're asking appropriate questions. They're advocating in different ways, and they're bringing up concepts and ideas without even being prompted. It's just part of their core now. So it's interesting. We notice our students collaborating and advocating differently, and that is huge. They are centering Indigenous worldviews that make sense to the person and their community. They realize they are not the expert, and their teachers are not either. But what we are advocates and we're helpers, and we're able to center that work. We are hoping to conduct community focus groups moving forward to engage with and in community in supporting evaluation and monitoring. We're looking to understand how to thread in more land-based learning concepts as a medium for culturally relevant patient education. As I mentioned, we're also looking to center Indigenous worldviews in terms of our rubrics and our methods of evaluation. It is, again, something a bit of a curve for us, but something we're not used to, but something we're very open to changing. Here is our first champions training that we conducted with our immediate group at the college and our steering committee, as well as our clinical partners. And this was our first cohort of students. Our steering committee's here, our clinical partners are here. It was a great day, and we had RNAO come from Toronto to come do this work. And in the 26 years that I've been involved with RNAO, RNAO has always been amazing. I mean, there's no doubt about it. But I have seen a ginormous level of support for this work over the past 3 years. I phone, the phone rings once or twice, someone answers. There's always a solution, and if there isn't, there's one coming up real quickly or connections to someone who is. So if you're thinking about this work, highly recommend it, and I would love to help you through it. Here's some pictures of us at the college. We have our community booths that we've set up. We've had panel discussions. We have had Dr. Grinspun here on the lower left doing a book signing in Thunder Bay with the students. And above that, you'll see our BPSO focused library section that is front row center. As you walk into the library, you'll see the best practice guidelines. Everybody knows the orange and green, and non-nurses are looking at these guidelines, and non-nurses are thinking, wow, like this is nursing knowledge. These are nursing problems with nursing focused solutions. And what does that sound like? A care plan. It sounds like NANDA. It sounds like nursing diagnoses, but it's in this beautiful guideline, and we teach our students how to apply that. So that is me, and that is my presentation. Um, it was my pleasure to do that presentation. I hope you'll pepper me with some questions, and the floor is yours. I will press stop sharing, I believe. I think that's what I do next. So I'll stop sharing, and I will turn the presentation back. Oh, thank you. It's been done for me.
Thank you so much, Michael. What an amazing presentation and just so much knowledge gained there. Thank you for taking us on your BPSO journey, and congratulations to all the success that your team has had, and kudos to your students. I've been able to speak to some of your students, and they just really thrilled with the nursing program and the depth of all the these amazing changes that you're making and weaving through the program. So important. So I'm opening it up to questions. Please feel free to raise